In this particular masterclass, we are going to learn about adult polycystic kidney disease. Now, what happens in adult polycystic kidney disease, also called as autosomal dominant polycystic kidney disease, is there is progressive formation and enlargement of cysts. These cysts are primarily in kidney and they are all epithelial lined cysts. Okay, so there is a formation and enlargement of this epithelial lined cyst in the kidney. Now these cysts grow with age, and eventually because of the growth of these cysts, even the kidney will start getting enlarged. And to just give you an idea, the kidneys become so enlarged that they will fill up the entire abdomen and even go up to the pelvis. So very enlarged kidney in these cases. And this becomes very important because most of these patients will end up in end stage renal disease, so they will need dialysis, and in these cases peritoneal dialysis is not possible because hardly there is any peritoneal space left. So this is again a very important point. Most of these patients, when they go for renal transplant, normally in renal transplant we never touch the defunctional kidney, but here pre-transplant nephrectomy is also done. So these are the two important points related to the increase in the gross size of the kidney. So again, adult polycystic kidney disease, there is a formation of epithelial lined cysts in the kidney. Let's look at the genetics part of it. So there are two genes involved which are defective. One is polycystin 1 and polycystin 2. So you have to remember that polycystin 1 is in chromosome 16, PKD1 gene, and because of that there is a defective polycystin 1. When we talk about polycystin 2, it is present on chromosome 4. So both the positions have been asked in the examination. A very peculiar thing about this adult polycystic kidney disease is that it has very high penetrance but variable expression. What do I mean by that? When I talk about penetrance, which means transmission from one generation to another generation to the next generation. So the disease will be transmitted with higher frequency from one generation to the next Okay. What do I mean by variable expression is that in a generation, let's say there are three siblings, all have this adult polycystic kidney disease gene defective, but they will have variable expression, which means one of the sibling will have a very early manifestation and the other may have no manifestation at all, and the third one may have showing symptoms at the age of 40, 45, 50. So even though they have the same gene, but their expression will be variable. So these are the two important points from genetics point of view which you have to remember. What we primarily are going to learn is adult polycystic kidney disease, which is also called as autosomal dominant polycystic kidney disease, but there is also autosomal recessive polycystic kidney disease. Autosomal recessive polycystic kidney disease is primarily seen in your children. So the age of presentation is much earlier. Autosomal dominant because it's a dominant transmission, genetic transmission, almost 75% expression in next generation, whereas autosomal recessive only 25% will express in the next generation. There has been a lot of questions regarding the the position of the cyst in various cystic kidney disorders. Okay, so let's look at the position of the cyst, because if there is an image based question you will be able to answer it. So when we talk about autosomal dominant or adult polycystic kidney disease, remember in this the entire kidney is filled with cyst. When we talk about autosomal recessive or children polycystic kidney disease, here all the cysts are present radially. The third condition where cyst can be present is called as medullary sponge kidney disease. Now, medullary sponge kidney disease is a congenital disorder, and here there is a cystic dilatation of the collecting tubules. It can happen in one kidney or it can be bilateral. Now, the fluid-filled sacs are there in the tubule and they are within the medulla. So here they will be inside the kidney. Okay, so this is the position of the A, and remember these cysts they are grossly enlarged and they keep the urine from freely flowing through the tubule. The symptoms will be very similar to what we are going to see in adult polycystic kidney disease, but remember the most important point which I want to highlight is the position of the cyst. The last condition is medullary cystic disease. Okay, it's again an autosomal dominant kidney disorder. It's a interstitial sclerosis. Here The cysts are placed to the periphery of the kidney. Okay, periphery of the kidney only. And this is a relatively a very slow deterioration of the kidneys present. And so this is different cyst according to the place where they are present, where the position of the cyst. If you are given an image based question, based on these diagrams you'll be able to solve it. Now let's look at how these patients of polycystic kidney disease will come to you. Most of these patients are asymptomatic till third or fourth decade of life. The usual age of presentation is 30 to 45 years. What is the most common presenting feature? The most common presenting feature will be flank pain. However, it is very interesting why this flank pain happens may differ in different patients. Some patients may present flank pain because of the stones which is formed. Look, it's a malformed kidney. So they will be increased in the formation of the stones. Sometimes there can be a bleeding in the cyst itself, and because this cyst do not communicate with the collecting system of the kidney, generally the blood will not come in urine. They will get accumulated inside the cyst only, where they will disintegrate and there will be production of hemosiderin, and so it will give a brownish black color to the cyst. Okay, so even bleeding in the cyst. And why this bleeding in the cyst will cause pain? Because kidney we know is covered by garrota fascia, and that garrota fascia will, once it is stressed, it will cause pain. Also, sometimes even UTI can cause pain. So the next common presenting feature will be recurrent urinary tract infection. Again, because of the malformed kidney, there is much increases chances and incidence of pyelonephritis. Now, generally the UTI pain will be pain at the junction of the costovertebral junction. So that is the most common. Again, in clinical MCQs, they can talk about microscopic cast in the urine. So both these findings, tenderness at costovertebral junction and microscopic cast, both will give you a indication that we are talking about UTI. As already told, there will be increase in the stone formation. However, very interestingly, these stones are primarily urate stones. Overall, the most common stones are calcium oxalate stones. Okay, but in your polycystic kidney disease patient, the most common stones will be urate stones, and this forms a very important MCQ. These patients also have a very high incidence of renal cell carcinoma. However, what is interesting is these renal cell carcinoma in these patients will be bilateral, will be multicentric, and sarcomoid type. So this is again a very important MCQ. So not only they have increase in the incidence of renal cell carcinoma, but these patients generally they will have bilateral multicentric renal cell carcinoma. Because of the progressive enlargement of the cyst, there will be decrease in the GFR. And what will this decrease in the GFR do? It will progressively increase the renin. Okay, because the GFR is decreasing, so renin will increase, and this increase in the renin will cause retention of sodium, leading to hypertension and all the hypertension related symptoms. Especially, they may present with a daily headache. So these are the general clinical symptoms which you will see in your polycystic kidney disease patients. Again, in examination, they can cause you, they can ask you about conditions where there is a decreased renin. So Riddle syndrome, Conn syndrome, all these you are going to learn in different lectures, but they are the conditions with low renin hypertension. Okay, this is polycystic kidney disease is a condition where there is an increase in the renin and increase in the blood pressure. So these were the clinical features of adult polycystic kidney disease, but these were the features which were renal manifestations. In examination, they are going to talk primarily about the extrarenal manifestation. So which is the most common organ after kidney which is involved? That is liver. So you will have liver cyst. Again, here they will be lined by the biliary endothelium. And remember, this question has been asked. This is the most common extrarenal manifestation. Apart from liver, where can the cyst be there? It can be in the pancreas, it can be in the spleen. And mostly these cysts are asymptomatic. Also, in the central nervous system, you can have aneurysms, and these aneurysms can present as subarachnoid hemorrhage. And this subarachnoid hemorrhage, in the lecture of subarachnoid hemorrhage, I have talked about warning leaks causing excruciating thunderclap headache. Okay, so that can be there. Also, there can be arterial, vascular malformation, and again, that can cause symptoms of stroke. So this is the extrarenal manifestation as pertaining to central nervous system. When we talk about cardiovascular system, they can be mitral valve prolapse, which can, they can indicate in the question like mid-systolic clicks, and they can be tricuspid regurgitation when they can talk about pansystolic movement. So in an examination, if they use, these terms, don't get, confused that this is primarily a cardiac case. So read the entire thing, and then you will know that even in adult polycystic kidney disease, you will have some cardiac manifestation like mitral valve prolapse or tricuspid regurgitation. When I talk about GIT, the most common manifestation will be colonic diverticulosis. Okay, and this colonic diverticulosis will present with, recurrent abdominal pain, constipation, or even bleeding in the cyst, which may come in danger. So this is the extrarenal manifestation. Again, a very common question which is asked is, what is the most common cause of death in these patients? So never answer renal failure. It is primarily the hypertension related complications which will cause death in these patients, like, left ventricular hypertrophy and all that. Okay, that will be the primary reason of, or the most common cause of death in these patients, because most of these patients will have renal failure very late. Okay, how do we work up this patient? We will first do a KFT to, check the renal function. We'll do a urea, we'll do a creatinine, the ratio. We can also do serum electrolyte, because potassium will keep increasing in, stage 3 and stage 4 CKD. We can do a CT abdomen or an MRI abdomen, even an ultrasound to pick up these cysts. So what is the number of cysts which, if found, we will confirm the diagnosis or at least raise a high index of suspicion toward adult polycystic kidney disease. If the patient age is from 30 to 60, then more than two cysts, will make you think towards this diagnosis. If the patient age is more than 60, then more than four cysts. And remember here also, T2 weighted MRI with gadolinium as a contrast is much superior, because first it will have very minimal renal toxicity. So T2 weighted uh, T2 weighted MRI with gadolinium as a contrast, and also it can pick up very small renal cyst. Even cyst from 2 to 3 in size can be picked up. So very early diagnosis can be there. Okay, we to confirm the diagnostic genetic studies has to be done where we see the actual defect of these genes. We can go for MRA head for the vascular malformations, or or berry aneurysms in head. We can do an echocardiography for cardiac cardiac abnormalities, or we can even go for a berry enema for diverticulosis. So based on what are the, even extrarenal manifestations we have to look up for. What are the general workup for colonic diverticulosis? Again, very favorite question in examination. You can do an enema, you can do a sigmoidoscopy, and you can even go for a CT scan. What are the investigation you will specifically do for berry aneurysm? Because if they rupture, okay, then there will be a subarachnoid hemorrhage, and you will lose the patient very fast. So non-contrast CT scan, we can do a CSF, and we can do an MR angiography. So these is the general workup which we do for these patients. How do we manage these patients? So control of hypertension, because I told you that most of these patients will suffer, or the most common cause of death in these patients will be because of complications related to hypertension. So control of hypertension becomes very important. So we will primarily use ACE inhibitors or ARB. Now, a lot of the students will ask, sir, ACE inhibitors will increase the potassium level. And here already, because of the CKD, the potassium levels are high. But remember, the benefit of ACE inhibitors outweighs the increase in the potassium level. So we will primarily use ACE inhibitors to control the hypertension. And if the potassium, if there is hyperkalemia, then we can use, drugs like patiromer or even potassium binders to decrease the potassium level. Okay, what is the target BP? Generally, target BP will be 140 by 90. In all the other cases, wherever a with target BP should be in APKD, we want the target BP to be lower, so it is 130 by 80. Generally, For CKD patients, we try to maintain target PPS 140/90, but in these patients, we will try to lower, we'll go for 130/80. We can, because these patients have recurrent UTI, we can use antibiotics, especially lipid-soluble antibiotics like cotrimoxazole, quinolones, and we will go for the culture sensitivity, and then we will. Okay. A lot of these patients will have very huge pain, so analgesia has to be given like tramadol. Remember, there is no role of carbapenem or pregabalin in these patients because primarily the pain is very high and it is not neuronal so much. A lot of these patients may have abuse of narcotics also because of the pain, so they will keep on taking painkillers. If nothing works, we can go for transcutaneous electrical nerve pacing. So what it will do is it will decrease the sensation of the pain. Okay. The treatment of choice is renal transplantation because it's an anatomical anomaly. And the most important point, as I've already told, is in these cases, we will go for a pre-transplant nephrectomy. Normally, whenever we go for a renal transplant, we do not touch the existing diseased kidney. We leave it there itself. Okay, whatever the GFR may be preserved with that kidney, we try to utilize it. But in these cases, because kidney is completely non-functional and it is enlarged, so it will keep on getting enlarged and keep on pressing even on the transplanted kidney. So that is why when we go for a transplantation in these patients, we go for a pre-transplant nephrectomy. There is another very promising drug, sirolimus, which is basically an mTOR inhibitor, and what it does, it inhibits the cell proliferation, and hence it can reduce the progression of cyst. So early diagnosis can be very helpful, especially with these new drugs. There are two drugs which are shown to decline the renal function. So they will slow the decline of renal function, that is tolpaplin and octreotide. So both of these have shown to decrease the decline of the renal functions. So this is about the management of adult polycystic kidney disease. Very small topic, but very simple and easy questions keep on coming up in your examination.